Greetings. Welcome to the Health Studies Collegium Gluten, Sensitivity, Celiac Disease, and GI Health webinar. I'm Russ Jaffe, an internist and clinical pathologist, biochemist, certified clinical nutritionist. I maintain fellow status in the American Society for Clinical Pathology, the American College of Nutrition. I'm a scientific fellow of the American College of Allergy, Asthma, and Immunology, of the Federation of Clinical Immunology Societies. I'm a fellow of the American Medical Laboratory Immunologists and an overseas fellow of the Royal Society of Medicine. I'm a senior fellow at the Health Studies Collegium Research Foundation and director and founder of ELISA Act Biotechnologies, as well as PERC. Our objectives for this webinar are to look at digestive health and the immune system, the role and the mechanisms of food sensitivities in their various kinds, and then a focus on celiac disease, its proper diagnosis, gluten and non-gluten sensitivity versus intolerance, and the complexity as well as elegance of our current understanding, and then the integrative management to remove obstacles to recovery using a physiology-first approach, the alkaline way. Let's begin, if you will, at the beginning. Digestive health is about converting food into energy. So, eat what you can, assimilate, utilize, and eliminate efficiently and without harm. Eat those things that can be digested completely, so they're not foreign to the body. They're just elemental building blocks. Bring them into the body and utilize them efficiently, and then eliminate the waste products promptly so they don't bioaccumulate. Now in the upper right-hand corner, you'll see a little book called Soil in Your Health by Beatrice Trum-Hunter, and I have found her to be a reliable, accessible, and easily understood voice for these complex interrelationships between us as people and the source of our food energy, that is, the soil, air, and water in which they're grown. On the lower right, you see a diagram of digestion starting with the eyes and what the eyes see, and then first the little bit of food that gets masticated, chewed in the mouth, sends signals to the brain about the central nervous system brain, about what is coming in, that then sends messages to the gut nervous system so that the body can prepare for the correct balance of digestive juices. Quite elegant, yet often overlooked, the first stages of digestion, and when we inhibit the upstream problems, the downstream issues become greater and more problematic. So, learning to live in harmony with what we consume is an important opportunity, which we'll discuss in a bit. Here's a scanning electron micrograph showing the microbiome, showing the elegant organisms that are populating our guts. There are generally 10 times more organisms in our gut than even the elegant number of cells in our body. So we contain within us this incredible interrelationship and interdependence of microorganisms that either feed each other or feed us in the process of converting food into useful energy. Now, back in the 70s and 60s when I was trained, I was already told that there was an epidemic of epidemics in regard to digestive problems. There were and continue to be the common complaints: heartburn, abdominal pain, gas and bloating, constipation, diarrhea. And then there are the comorbidities, including irritable bowel syndrome, diverticulitis and diverticulosis, and Crohn's disease, ulcerative colitis. But then, and pervasively more so today, there's enteropathy, there's atrophy of the digestive tract. What we don't use and renew properly begins to slip away and atrophy. And then there's maldigestion and dysbiosis. That is, we don't break the foods down to their building blocks, which are helpful and never harmful. We have partially digested remnants that can get into us because of an imbalance or a dysbiosis in the microbiome. Now, with regard to optimal digestion and health, they are linked, and food intolerance affect nearly everyone at some point, according to the National Institute of Allergy and Infectious Diseases at the National Institutes of Health. Now, there are 4 food intolerances. They have 4 different mechanisms and types, and I'd like to briefly review those with you. First, allergic amplification, the acute allergy. Then, another kind of allergic amplification, delayed allergy. In both cases, a logarithmic or dramatic amplification of response due to either the acute or, quite separately, the delayed immune pathways. Then there's lack of digestive enzymes. That's an epigenetic acquisition. And enteropathy or atrophy, a separate category. Healthy immune responses mean the following. Healthy immune responses mean no allergies, means tolerance. It means the immune system can neutralize infections and allergens as they come in. This repairs us from daily damage, and the same immune system that's responsible for the defense work of neutralizing infections and allergens repairs us from daily damage, daily wear and tear, and also identifies and starts the process of deleting abnormal cells of cancer cells. Indeed, everyone makes cancer cells every day, and fortunately, while our immune system is robust, they're identified by surveillance cells, the same cells that would neutralize infections and allergens, that would repair us or start the repair process from daily damage, are also the cells that help identify the surface markers, the abnormalities of cancer cells, and program them for cell death. When we get into adaptive immunity, that means a loss of tolerance. That means a loss of the immune system's ability to neutralize foreign invaders, repair us, and defend us against cancer. And here you see on the left a diagram that starts in the upper left-hand corner where the epithelial border, this is inside the tube of the intestine, where digestive products pass through a border, an epithelial lining border, a surface, and in this case, they're partially digested, so they're antigens, they're large enough to be foreign, and they're captured, in this case, either by macrophages, NK cells, the eosinophils, or if there's too much of them, then by antigen-presenting dendritic cells that then program B or T cells to remember that this is an invader. Now that memory can be helpful when we recover, neutralizing, beneficial, protective, or those antibodies can be harmful. So just knowing that an antibody is present doesn't tell you its function. There are helpful and also harmful antibodies, and we'll discuss that later in this webinar. Now, gut first responders, these dendritic phagocytic cells, when I was trained, the Peyer's patches, or the mucosally associated lymphoid tissue, the gut-associated lymphoid tissue, about half of the immune system, lines the GI tract, it lines the gut. It provides half of the 50 billion total phagocytic dendritic cells, so 25 billion of these cells are lining the intestine in the purple circles or patches that you see on the left, first en face and then at a higher magnification. And each one of these capture cells is able to recycle 50 foreign invaders at any time when they're energetic and healthy. So a healthy person can recycle 2.5 trillion foreigners at any moment. Now this assumes that everything is okay and that digestion is of a healthy nature. These are also the cells that require energy most quickly and as a consequence can run out of antioxidants, buffering minerals, become acidotic, become metabolically susceptible to oxidation, all of which impair their ability to do their first response job. Let's look first together at food intolerances in the way they're most commonly understood. We start with dysbiosis, an unhealthy microflora in the gut. The microbiome is influenced by stress, by environmental toxins, by medications we may have received that alter the microecology. And when this is not replenished, when this is not rehabilitated, when this is not restored, we can have a downregulation of elective protective enzymes. These are the ones needed for full quality of digestion, but not needed for survival. So lactose intolerance is an acquired lactase enzyme deficiency. Acquired in the sense that very few people in childhood who have a healthy digestion lack the enzyme lactase. In young adulthood, people without symptoms often acquire a lactose intolerance because their digestion has switched from elective protective mode to closer to survival mode until it can be restored. And in that survival mode, you downregulate anything that's not essential for survival, like all the elective protective enzymes. And so lactose that comes in through the diet, as you see in the lower left, when it meets insufficient lactase enzyme in the small intestine, delivers that milk sugar or lactose to bacteria in the colon, where they're metabolizing the lactose, and you have as a consequence gas, flatulence, abdominal pain, and the like. What is true for the epigenetic downregulation of lactase is true for peptidases and lyases and various other enzymes that are elective and protective and present in healthy digestion with a healthy microbiome. Many of these enzymes are produced by the bugs in our gut, not necessarily produced by us, but produced by the bugs in our gut when we're good enough to them to allow them to have a truly healthy microflora. Another example of what is acquired food intolerance, but of a different mechanism, is celiac disease, where you have an autoimmune attack of the duodenum leading to atrophy and downstream digestive problems, systemic problems, quite different from gluten intolerance, which is acquired difficulty digesting gluten, and when digestion is strengthened, then one can have the staff of life or gluten at will. Then there's acquired IgA deficiency, or SIGA, secretory IgA deficiency, another and common acquired maldigestion, acquired disorder. Indeed, the most common immunodeficiency in adults is IgA deficit, secretory IgA deficit, usually because the infant's digestive tract doesn't fully mature, and then with the assault of challenging substances, environmental toxins, and processed foods, and all that goes with that, the body then switches towards a survival mode away from elective protective mode and downregulates those elective items that protect us, like secretory IgA. Now, the body wants to get back to elective protective mode, and I'll be talking in a few minutes about how to do that. And then there's simple maldigestion, where we don't have the proper microflora, we don't have the proper probiotics and prebiotics to allow for a healthy digestion. Now, an overloaded immune system means acute and or delayed allergies, chronic illness. It means inflammation. And inflammation we have rethought at a more molecular and fundamental evidence-based level. It's really acquired repair deficits. An overloaded immune system does mean an increase in digestive remnants recognized as foreign by the body, and it also, most importantly, means an increase in chronic, in degenerative, and in autoimmune illnesses. You'll notice on the bottom of many slides that there's a reference for those of you who want to look at the more detailed evidence in support of these comments. Now let's review allergy briefly. There's acute IgE-mediated type 1. IgE is an antibody, and the type 1 immune reactions are histaminic. The immune system responds to protect from sensitized antigens with this amplified reaction. Dendritic cells designed to ingest and recycle can't keep up with the load. In healthier people, an increase in IgG4 antibodies counterbalance the IgE, so you can have an elevation of IgE, and if it is matched with an equal elevation of IgG4, you will have an increase in IgE without the symptoms of acute allergy. People who are allergic or atopic do not increase their IgG4 antibodies, and then the IgE antibodies act on these phagocytic cells, these granulocyte-rich cells, and histamine, a powerful amplifier, can be released. Delayed hypersensitivity is even more interesting, elegant, and complex, but with recent advances can now be used and understood in clinical practice. Gel and Coombs in the 1960s showed that there were 3 different independent and interdependent pathways, and it's our view that if you want to understand the immune defense and repair system, you need to get a functional assessment of all 3 categories for each individual. And this can be done through the culture of lymphocytes. We'll talk about that in just a few minutes. But to review the categories, they are types 2, antibody-dependent, type 3, immune complex, and type 4, direct T-cell responses, no antibodies in circulation. Now, the type 2 antibodies are complement fixing, they're provocative, they're harmful, IgG, IgM, or IgA. And if we want to understand just that category, we do need to look at all 3, not just any one, not just the memory IgG. And then there are also lectins that bind to various cells as another provocation. Now, type 3 immune complexes mean IgM antibodies directed specifically against IgG antigen units, where the IgG antigen would be so powerfully harmful that the body wraps an IgM around it in order to help remove it from circulation. If, however, the spleen and the liver are not able to keep up with the work of removing the immune complexes, then they can land on blood vessels and cause vasculitis or other what are called immune complex disorders. And type 4 are direct T-cell responses, no antibodies needed, T-cell mediated delayed responses, macrophages that engulf food allergens, T-cells and macrophages release cell signaling interleukins, cytokines, communication molecules to start an immune cascade that leads to inflammation, repair deficit, and comorbid conditions. Here we see a picture to give you a sense of the interaction and interdependence of what's going on in the mucosa, in the interior lining of the GI tract. What you see here are different colors indicating different categories of structural or functional elements. And it, to me, is not just visually interesting, it illustrates how interdependent the GI tract is and why it's important for us to take a systems approach, a functional approach, not a static approach or a one variable approach to understanding GI health. Now let's look at allergy lab tests and what they measure and how they're useful. Type 1 allergies can be measured by RAST or skin tests in most conditions, most situations. And as you see on the right, in the white, if you will, slice of that pie, there are type 1 acute IgE or RAST detectable IgE allergens, and they form but one small part of the overall immune response. Delayed allergies. Now there's a category. Lymphocyte response assays are needed to tell good from bad because you can have neutralizing and protective antibodies as you have, say, after a childhood illness or after you recover from some stress. So you can get sensitized at a time of stress. Then you can recover from that stress and the body then says, oh, I remember that was a stressful time and I did acquire a reaction to that substance, but now I'm going to neutralize that if it comes in. So memory antibodies are 3/4 or more helpful, barely 1/4 harmful. And if you just measure the antibody, you don't know its function, and you may then end up asking people to substitute a lot of things that they really are protected from, while missing the immune complexes, missing the other antibody categories, missing the T-cell mediated responses, so the person will have only a transient benefit. So for delayed allergies, as you see on the left, lymphocyte response assays are needed to tell good from bad, and the LRA by ELISA Act is what we've developed and offer as an advanced procedure to cover all delayed pathways functionally, measuring only the harmful and not the helpful antibody or other immune responses. And this is simply because lymphocytes do react to harmful antibodies and activate and send out cytokine cell messages, but they do not react to neutralizing and protective antibodies because those antibodies don't fix complement that's necessary for the harmful activation. Now, there are three types of methods used in labs for allergy tests of a delayed nature. These are IgG, also known as ELISA IgG, EIA IgG, IgG subtypes, IgG4, or other measurements. And they are static. They measure the presence or absence of antibody. They give no information about function, and therefore, from our point of view, are not only limiting in their ability to discriminate, but they're also limited in that they only measure the memory IgG. They don't measure IgA or IgM. They don't measure immune complexes or the T-cell responses. Then there are automated cytotoxic or cell size methods, looking at particles of a certain size and assuming that that's an immune reaction when it often is not. And then there are lymphocyte response assays, say as the LRA by ELISA Act, which is a functional and ex vivo procedure. It measures reactions just as they happen in the body, but under the controlled laboratory conditions. Now let's look at those three categories in a bit more detail. The in vitro IgG assays in all the permutations measure the presence and the amount of IgG antibody. They miss other type 2 associated antibodies like IgM and IgA, which can be important. They are static, they're non-functional. They make no distinction, good from bad antibodies. In fact, they imply that the presence of an antibody is harmful. Yet only complement-fixing and reactive antibodies harm. 75% of antibodies, whether they be to foreign substances or infectious substances, are actually protective and not harmful and reactive. They're actually neutralizing and beneficial to the body. But if you just measure the antibody presence, not its function, you cannot distinguish. And what about the automated cytotoxic or cell size methods? Well, using a modified particle or Coulter counter, you can detect particles of about 10 microns in size. In theory, as white blood cells react, they change size, detect those changes, and you know which antigens elicit reaction. But in fact, the method counts any particle of 10 microns, not only white blood cells. So red cells that stack, rouleau-formed red cells, due to changes in the electrostatics of the cell and an artifact, or a little bit of microclumping of platelets, can induce a 10 micron particle that tells you nothing about the immune system and is actually artifactual, yet reported, because you're measuring all particles at 10 microns, you're not really measuring lymphocytes. Now the LRA by ELISA Act is completely different. Here a simple 1 ounce 30 cc blood sample can be used for over 490 or more tests. This is a micro-miniaturization of the older procedures so that we can test many substances, the foods, food colorings, additives and preservatives, environmental chemicals or toxic minerals, medications, molds, danders, hair and feathers and herbs. Any or all of these can be measured using the lymphocyte response assay LRA by ELISA Act. Now the ELISA here is an amplified procedure done on the surface of a living lymphocyte. That's why it's ELISA Act, an advanced cell technique, the first time that ELISA amplification has been married to cell response assays. And that is what has allowed us to micro-miniaturize the procedure so we can do hundreds of tests on 1 small ounce of blood, whereas originally, when I started this work, one substance would be measurable in 1 ounce of blood over 3 weeks with a 30% variance. Not very useful clinically. With the new LRA by ELISA Act, we can do hundreds of these procedures on the same 1 ounce of blood with a 3% variance in a matter of 4 hours from the time we start the procedure. Managing food reactivities has to do with substituting. Substitute for the foods that are detected functionally as harmful by LRA by ELISA Act tests. And in addition to identifying more accurately and comprehensively what people react to, we provide an interpretation that offers you an alkaline diet, targeted supplementation, mental and physical actions to evoke healing, and a rotation diet if your practice calls for it. The alkaline way diet has to do with eating the foods that are alkaline after metabolism. And here you see a chart that's a little hard to read, and you're welcome to contact our client services group or check online at the websites I'll give you at the end to download these materials for your use. And there are foods that alkalinize or are against cell acid because every one of our cells makes an excess of metabolic acids each day, yet in function, cells must be alkaline. So we are alkaline in function, yet acidic by design, and so we have to take in buffering minerals and other alkaline-forming elements that are shown, for simplicity, to the left of the midline, progressively more alkaline, and to the right of the midline, progressively more acid, the foods that you might eat. So most fruits and vegetables, most whole fundamental low on the food chain foods, including sprouts, nuts, seeds, herbs, as well as pulses, fruits, and vegetables, are alkaline forming, but not all, and that's why the chart is so helpful for people to select the foods that will promote their health and evoke healing responses. Now, NHANES is the National Health and Nutrition Survey, and the NHANES 3 and 4 surveys show that 87% of the people surveyed had one or more essential nutrient deficit. So they were not even able to take in the minimum amount of nutrient needed to avoid deficiency diseases like pellagra and kwashiorkor. 58% of people, as you see in the first bullet, 58% of people had 2 or more deficiencies. In regard to essential fats, the omega-6 to omega-3 ratio for many people was 50 to 100 to 1, whereas the goal is about 4 to 1 for health. An imbalance in any essential nutrient will cause a downstream amplified risk of ill health. So even using daily values, the minimum, not the optimum intake, 87% of people were deficient in 1 or more essential nutrient. 58% had 2 or more deficiencies. So the standard American diet can be described as sad. Impaired uptake, acquired atrophy and enteropathy of the GI tract, medications that reduce healthy probiotic microflora that's not then replenished, diets that are deficient in probiotic fiber or enriched in environmental toxins, lack of restorative sleep, and epigenetic phenotypic modulation all contribute, the processing of our diet, all contribute to the fact that the standard American diet is really a benchmark for promoting, not reversing or avoiding, ill health. Now, nutrients do enhance outcomes. Prebiotic fibers help nourish the probiotic essential microflora, and we recommend 40 to 100 grams per day through whole food and supplementation of unprocessed fibers so that you can have enough of the prebiotics to feed the beneficial probiotics. For probiotics, we recommend 10 to 40 billion CFU, or colony-forming units, a day for maintenance, and 40 to 100 billion CFU per day for therapy. Live, dairy-free organisms are what we recommend for supplementation. If you're tolerant to kefir and to other fermented dairy products, that is fine. If you're tolerant to fermented foods, like fermented and pickled vegetables in the raw state where the organisms are still alive, that is also fine. So we're meant to take in our probiotics primarily from our diet. We're meant to take in our prebiotic fibers primarily from our diet. But too many people take in only 10 to 20% of the prebiotic and probiotic essentials and end up with maldigestion and all the downstream consequences. The third point here is that glutamine, when recycled with PAC, pyridoxal alpha-ketoglutarate, allows the intake of 1.5 to 6 grams per day, taken on an empty stomach, say on rising and or before bed, and a half an hour before exercise is another good time to take them, will allow you to energize and repair the gut through glutamine without overwhelming the body and raising the glutamate potential excitoneurotoxin activity. So we recycle glutamine to get the benefit. We entirely avoid, by staying within physiologic dosing, any risk of glutamate buildup. And this recycled glutamine is an essential energy source for the gut. Glutamine and butyrate are what the gut uses for quick start energy. And so replenishing glutamine without raising glutamate is one of the breakthroughs of the last decade that is so helpful to so many in restoring their digestion. Now, nutrients do enhance outcomes. Enzyme buffering minerals such as magnesium, the fifth but forgotten electrolyte, if you will, has uptake block overcome with concurrent choline citrate. So when you take ionized magnesium and choline citrate at the same time, you can facilitate uptake of magnesium through neutral pores. We can go through the chemistry another time, but the normal block to magnesium uptake that leads many people to say, oh, I've taken some magnesium supplements. They give me loose stool or the runs because they're not absorbed, has been overcome. And we now have forms of magnesium, when combined with choline citrate, that can facilitate uptake and lead to a beneficial replenishment of the magnesium to balance the calcium in the body and to buffer and enzymes and activate the enzymes inside the cells of the body. Buffered, reduced 100% L-ascorbates, the physiologic form of vitamin C, are also recommended. And since ascorbate is the regulating or recycling or regenerating antioxidant, it sacrifices itself so that other antioxidants can be maintained. The amount of ascorbates we need can vary dramatically. Healthy people have a half-life of ascorbate of 30 days. Unhealthy people can have a half-life of ascorbate of 30 minutes. You'll need orders of magnitude more. You'll need dramatically more ascorbates if you have a short half-life versus an efficient recycling and regeneration of the ascorbates with a long half-life. Then we recommend multivitamins with energizing Krebs salts and cofactors, and very often hydroxycobalamin, the physiologic form of B12, is needed, and it's needed in a way that gets in through the mucosa of the mouth, because downstream there's been so much atrophy that uptake is poor. So we look at the physiology, we look at the way people actually are, and we find ways of getting in the reparative, restorative, and essential nutrients like hydroxycobalamin B12 in a physiologic form. A colleague called me, for example, because a patient was receiving injections every several weeks of B12 because of neuropathy and other consequences, was put on this hydroxycobalamin, and barely a month later had gone from a level of 200, which was the level achievable with injections, yet still low, went from an injection-induced level of 200 to an oral uptake level of 800 in barely a month, with symptomatic reduction in the discomfort and the neuropathy that the patient had had. Other nutrients to enhance outcomes include omega-3 and omega-6 essential fats. We want to balance the omega-6 excess by increasing omega-3s. We do want to change the oil of most people by increasing their EPA-DHA active omega-3 intake. ALA is an omega-3 fatty acid, but in the people who need the active EPA and DHA, conversion is poor, and so we recommend taking directly for first 2 to 3 months to change the oil, EPA DHA, and then switching to a comprehensive omega-3, 6, 9 CLA DHA combination for maintenance. There are detoxification factors such as the sulfur amino acids found in the 5 to Thrive foods. These are garlic, onions, ginger, brassica sprouts or broccoli sprouts, and eggs, and one or more of those should be a staple in the diet. You don't necessarily need all of them, but you do need one or more as a staple of the diet. And coenzyme Q10, the shuttle that keeps the battery recharging inside the cell, with mixed natural tocopherols or vitamins E, micellized in 100% rice bran oil, gives dramatically better clinical results, threefold better uptake and peak levels of coenzyme Q10, and then more protective stress response, more protective antioxidant activity at the membranes and inside the mitochondrial battery. And the fourth bullet on this shows cholecalciferol, micellized with MCT and mixed natural tocopherols to maintain a 50 to 80 nanogram per ml level for the 25-hydroxy-D. So we want to take in the precursor to vitamin D. We want to get that in. And Dr. Mike Hollick, a vitamin D expert, tells me that over 40 million Americans cannot take up vitamin D from their lower GI tract. For them, it's really important to get the mucosal uptake, say, in the mouth. There are many comorbid conditions that are associated with food reactivities, and here you see a substantial overlap between the subtypes, and if you address only one type, say type 2, which are the antibodies, you will miss the type 3 and 4, and you will therefore get only partial responses. So whether you have an acute type 1 allergy, or a functional, harmful type 2 antibody, or a type 3 immune complex, or a type 4 T cell, we want you to know functionally across all those delayed pathways, type 2, 3, and 4, what the provocations are, what to do about them, and then acquired intolerances, the dysbiosis, the lactase deficiency that leads to lactose intolerance, as you see on the far right. Some aspects of celiac disease and IgA deficiency and maldigestion and gluten and gliadin intolerances can then be corrected because you're restoring competence and resilience to the digestive system. Now, medications, maldigestion, and food reactivities do go together. The maldigestion promoters, well, they include COX-2 inhibitors that prevent repair. They include antibiotics that kill the microflora. They include histamine antagonists and proton pump inhibitors that reduce stomach acid and impair B12 and mineral uptake. And metformin, a very common medicine given to help control blood pressure and blood sugar. Metformin promotes B12 deficiency. So anyone who's on a histamine antagonist, a proton pump inhibitor, or metformin for their high blood sugars needs to take in B12, and B12 in a form that will get in safely and effectively the hydroxycobalamin that we recommend. 2 of 3 people have a chronic illness, and hidden food allergy plays an etiologic, a causative role, according to the ACAAI working group some years ago. Celiac disease, it's in the news. What is it? And why is there so much now? Well, the best information that I know of about the celiac incidence is that it is between 1 in 250 to 1 in 150 people, less than 1% of the population. Yet, there's much greater awareness of potential celiac problems that are often confused with gluten intolerance. The importance is quite profound. Celiac disease means a lifetime of meticulous gluten avoidance and work to restore digestion. But celiac disease is very different than acquired epigenetic gluten intolerance, where when you restore digestive competence, the body can break down the hard-to-digest gluten-rich foods like wheat and other grains and utilize them efficiently. So there's a profound importance to which aspect of gluten is the problem, and that's what we're going to talk about in the next few minutes. For celiac disease, this, I believe, is the gold standard of how to diagnose it. If you have an index of suspicion, you do a history and physical exam, you do a TTG or other similar serology to see whether there are any immune reactions at all, knowing that the serology doesn't distinguish helpful from harmful. If the TTG is abnormal, then you see, if it is abnormal, then you need to do an endoscopic duodenal biopsy, because it's only when you look under the microscope at the histopathology that you can confirm celiac disease and the need for a lifelong gluten-free diet. On the other hand, if we go back up to the TTG, if it's a protective TTG, then you might still go ahead and do the biopsy, but it'll come back normal, yet you have a digestive problem. And if the TTG is not elevated, then celiac disease is so unlikely that a biopsy is not warranted. You should assume intolerance and promote digestive health and go by results. Now, celiac disease is an adaptive immune response, and while this is a bit complex, it does show the issue in a diagrammatic way. Gluten or gliadin, partially digested remnants, can get in. A gliadin peptide is foreign, and if the first responder cells are overwhelmed, then the antigen-presenting dendritic cells will process the gliadin and deliver it to a lymphocyte that will then develop an immune response. Now, that immune response is harmful at times, but neutralizing and helpful when the body recovers. So we have memory antibodies that help us, and we have other antibodies that are harm-inducing. Most important to functionally distinguish between them. And then there are the cytokines like interleukin-15 that can amplify some of these reactions, and that's basically what this slide shows. Now here's a case example. A 50-year-old white male engineer, a father of two. The symptoms included lack of energy. His weight was stable despite 2,500 to 3,500 calories intake. Past history, social history, and family history were unremarkable. The physical exam showed a well-developed individual with slight conjunctival pallor. The lab test confirmed anemia, mild liver function test transaminitis, mild elevation of the liver functions, and 3 stool samples were negative for occult blood. Colonoscopy revealed a sigmoid polyp. Biopsies were taken. And an endoscopy was done of the duodenum, and a biopsy was taken. The histology showed normal villi, normal area. Duodenal biopsies on ultrastructure showed severe blunting of villi, crypt hypertrophy, lymphocytic infiltration of the mucosa. The patient was continuing to experience no GI symptoms, yet nonspecific symptoms frequently lead to delayed and misdiagnoses, which is increasingly common. The average time of suffering to diagnosis properly for patients with true celiac is about a decade. So we need to be more vigilant and think about the problem, even when the patient is asymptomatic, if our tests or if our physical observations or if the history are suggestive. Now, celiac disease and gluten sensitivities. Celiac syndrome is autoimmune. 80+% are hypersensitive to gluten, but there are patients with celiac disease that are not sensitive to gluten, and when you identify the autoimmune provocations and substitute for them, they do better. So while 80% of celiac syndrome is due to gluten hypersensitivity, another perhaps 20% is not, and a more comprehensive approach, such as allowed by the LRA by ELISA ACT test, gives you more complete information to manage the case clinically. Delayed allergies to non-gluten digestive remnants are key to success, yet often overlooked for those who don't use functional lymphocyte response assays to gain insight. Celiac disease and gluten sensitivity needs an assay that measures antibody function and is able to distinguish good from bad antibodies. IgG antibody measurement does not distinguish function. It does not distinguish helpful from harmful. Celiac disease needs more than antibody tests. Serology for anti-tissue transglutaminase, TTG, or EMA-IgA, or AGA or DGA are not predictive or consistent because the serology, the antibodies, can be harmful or helpful, and measuring the presence of the antibody doesn't tell you its function. You see on the right the difference between a nice, healthy, irregular, normal mucosa and the villus atrophy, crypt hyperplasia, malabsorption associated with celiac syndrome. At some point, and usually this is advanced, there can be weight loss, diarrhea or stool changes, abdominal pain and bloating, anemia of unexplained etiology, and yet many people for years have undiagnosed issues that would be more easily managed if we got more quickly to their cause. Symptomatology varies from severe to silent. Only a small bowel biopsy can confirm the diagnosis. Integrative self-assessments. The first morning urine pH, the first urine after rising, after 6 hours of rest, allowing the cells to equilibrate with body acid. The next self-assessment is a transit time, from the time you consume until you eliminate the food. How long does it take? And the last is an ascorbate C cleanse. Now, with regard to metabolic acidosis, are the cells too acid at a cell level? We recommend a simple pennies a day assessment that the individual can do at home. The first urine after rest is the one you want to measure. It's the only one that's predictive. So after 6 hours of rest, the next urine that comes out is measured with these color contrast strips. If it's yellow, you're too acid. If it's green, you're okay. If it's blue, you're too alkaline and you might have catabolic illness. We recommend something like the daily tracking chart. You put down the date, the time, the pH reading, and also how people feel. And they will routinely come back and report to you. The days they're more alkaline, they're less symptomatic, and they're more hopeful about their condition. The days they're more acidic, they're more symptomatic and less hopeful about their condition. So this is a way of engaging people so that they can see the relationship between their simple metabolism and their feelings and functions. In regard to GI transit time, average is 36 to 96 plus hours for Americans, allowing toxins to be reabsorbed, allowing metabolism to be drained, allowing chronic GI or systemic illness to emerge. A healthy transit time is 12 to 18 hours. And if you're less than 10 hours, that's too short. It suggests a short bowel syndrome, and malnutrition and malabsorption can emerge. The way to do a GI transit time measurement, the way we've refined it through the Health Studies Collegium and available to you online and through client services, are activated charcoal 6 to 12 caps, taking 1.5 to 3 grams of charcoal with 8 ounces of water in between meals, and marking the time. And then, when the black crumbly stuff comes out the other end, comes out the tush, you mark the time. The difference in hours is the transit time. If you want to know how much of the charcoal is usually adequate for people less than 150 pounds, 6 capsules, 150 to 200 pounds, 8 capsules, 200 to 250 pounds, 10 capsules, more than 250 pounds, 12 capsules. We mentioned ascorbate, and the C cleanse is the way to find out, in essence, the half-life or how fast people are using up ascorbate. Healthy people respond and recycle ascorbate very efficiently. They don't need very much. They can have a 30-day half-life, whereas chronically ill people can have a 30-minute half-life, indicating orders of magnitude more ascorbate required. Well, how much ascorbate does each individual need? Well, healthy people, we recommend starting on 1.5 grams, which is half a teaspoon of fully buffered, fully reduced all L-ascorbate powder, every 15 minutes. That's 6 grams an hour, and most healthy people will have their cleanse within 1 to 2 hours. Moderately ill people, we recommend 3 grams or 1 teaspoon of the powder every 15 minutes. That's 12 grams an hour. And within 2 to 3 hours, even most moderately ill people will cleanse. If a person doesn't cleanse within 2 to 3 hours, we recommend that they stop that day unless they feel impending cleanse, and then they should complete it. But if they don't feel much different after a couple of hours, we recommend coming back the next week and doing a C-cleanse at a higher level. And for chronically ill people, that typically means 6 to 12 grams, 2 to 4 teaspoons every 15 minutes, 24 to 48 grams an hour, and most even chronically ill people with a short half-life will still saturate their system, be able to energize and pump fluids and toxins into the rectum, and evacuate that as a C-cleanse. So antioxidant need varies considerably, whether you're a healthy person, whether only moderately ill or chronically ill, and that's because the half-life of ascorbate is the most wide in all of biology. Healthy people have a 30-day half-life. Unhealthy people can have as short as a 30-minute half-life. So the C-cleanse is an individual assessment. We use it to get the toxins pumped out and the cells energized with protective antioxidant ascorbate. Ascorbate requirements do vary considerably. Here you see 4 categories. On the far left, yellow healthy people. Next to that, bright blue, less healthy people. Light blue or turquoise is the bulk of chronically ill people. And then on the far right, a group in red that are severely unwell. If we look at the group in yellow, they calibrate on less than 4 grams. Their ascorbate requirement or their C-cleanse occurs on less than 4 grams. The bright blue calibrate between 5 and 10 grams. Their cleanse occurs between 5 and 10 grams. For the bulk, about 80% of people will calibrate between 10 and 130 grams. Their cleanse occurs between 10 and 130 grams. And then about 1 in 20 or so really ill people, yet still ambulatory, will cleanse over 130 or 40 grams. So the amounts vary considerably. Important to use the right form, fully buffered, fully reduced all L-ascorbate, and then let the individual determine their physiologic consumption rate, their physiologic half-life, their physiologic need for ascorbate in order to restore what the body needs so that antioxidants can help protect from oxidative stress and free radical damage. There are predictive lab tests, and we have re-stratified them to healthy goal values. And these include C-reactive protein. It should be less than 0.5 milligrams per deciliter for repair, because repair deficit is really what inflammation is. The high sensitivity CRP is recommended. You want an HSCRP of less than 0.5 milligrams per deciliter. Anything above that shows a repair deficit and a need for essential nutrients to stimulate immune repair mechanisms while also decreasing immune defense work. The second predictive test is homocysteine. It should be less than 6 micromoles per liter. This measures methylation, detoxification, and epigenetic modulation. The third is oxidative stress antioxidant sufficiency. The goal is to have oxidized fats in the LDL and HDL as near 0 as possible, and 8-oxoguanine as near 0 as possible. Oxidation of fats makes them harmful. Oxidation of the DNA base guanine makes it harmful. And so we want to measure and quantitate the oxidized fat in the LDL. We want to look at the LDL to HDL composition. We also want to look at the nucleus and whether it's under oxidative stress, and 8-oxoguanine is that measure. So for celiac disease, we want to go further, screen with the serologic static tests, but then progress to a biopsy and to a functional procedure to distinguish comprehensively what's needed to restore digestive and systemic health, LRA by ELISA Act, delayed allergy, functional tests, and the treatment guide that's an option for your use. Immune systems enhance function and stop burdens when approached in this way. Hospitable host to pathogens means that people have lost tolerance. Allergens can provoke symptoms. An overload of foreign reactive antigens is harmful, but memory antibodies that neutralize are helpful, and so a static serology test, an IgG kind of measure the antibody, only tells you that there's an immune memory, not whether that's a helpful neutralizing good memory or a harmful reactive troublesome memory. Under conditions where the immune system is under extra defense work, repair is deferred because defense needs to be done first. Only functional tests can distinguish the causes of immune overload, and after 25 years of doing this with over 60,000 cases in our database, we suggest going by results using this functional, integrative, comprehensive, yet very personalized methodology to assess the needs and to take action to resolve the risks, while also promoting the health. This physiology-first approach has to do with the immune system. We want to reset, renew, repair, and restore tolerance in the immune system. To make this comprehensive plan easier in practice, easier to lower the burden by substituting for reactive foods and chemicals and knowing hidden places where they can be found. Comprehensive plan that includes needed bioavailable nutritional supplements to rebuild the body's essential capacities and competences, and lifelong health, eating and living the alkaline way. We have a little monograph, The Joy of Food, the Alkaline Way Guide, and we recommend that to you as a tool for motivation as well as for the individual to take home with them to reinforce and extend your message and make it live in their lives with minimal burden on you. So the path to health then is based on understanding the following. Health is given to most of us, and most of us give it away before we pay attention. Many of us go through a phase where we're young and immortal, we can do anything, eat anything, or so we think, and yet our biological health bank account is being depleted. We start typically with a tenfold reserve, and if we replenish that, we remain in resilient good health. But if we use that up, then we not only develop symptoms, but we have quite a bit of recovery to do to get back to a resilient and healthy state. Bottom line, sustainable health comes from what we eat, drink, think, and do. And when we address what we eat and drink, think, and do in a comprehensive approach, we get a multiple benefit and often synergistic benefits. So, to paraphrase Hippocrates, Galen, Huang Ti, and the World Health Organization, health is more than the absence of disease. Health is the fullest physical, mental, and spiritual expression attainable by each individual.